Hi there. My name is Dr. Baker. I'm a board-certified, fellowship-trained neurosurgeon. Today, I will be talking about lumbar fusion. What is lumbar fusion? Why do people get this type of surgery? And what to expect after lumbar fusion? And in general, success rate of lumbar fusion and other related topic. Lumbar fusion technically is doing something to the lumbar spine, which is basically the four bottom vertebrae. This is called L5, L4, L3, L2, and there is an imaginary L1. And lumbar fusion is doing something that eliminates motion in one or more segment. Now, how do we do lumbar fusion? Back in the days where we did not have any of these fancy instrumentation, these rods, screw, cage, they would just go in there and drill down these particular parts of the bone called facet joints and make them raw and have the patient be in bed for weeks on end. And this raw drilling of the capsule of this joint would, after a while, solidify and become one piece of bone. And in an area where there is supposed to be disc, that disc starts becoming hard and becomes bone. But now, in this new generation, we have all kinds of fancy tools to increase the success rate of lumbar fusion and also introduce newer ways of doing lumbar fusion. The most common way of performing lumbar fusion is to put screws in particular parts of the bone in the lumbar spine called pedicle. So in order to do one level of lumbar fusion, you have to at least put 4 screws. 2 screws in one bone, 2 screws in another bone, interspersed between a disc space. Now, if you are simply putting 4 screws and connecting them with a rod, that is called posterior lateral arthrodesis or posterior lateral fusion. That's one type of fusion. Second, which is probably the most common type of lumbar fusions that surgeons use, is something called transforaminal lumbar interbody fusion. Long name. What does that mean? That means there is a specific part of the lumbar spine in the facet joint. You end up removing that facet joint completely to identify a nerve right underneath that area, and you get down to the disc space and you basically cut the disc and you get as much of the disc as possible to create what's called ventral support, which means support of the spine from the front. Remember, we talked about posterolateral fusion. All it is putting screws in the back, which is basically providing back support, but the front, where a lot of the weight is, especially if you're overweight, there's a lot of force in the front. It could potentially make the screws break, which you don't want. And to give it a higher success rate, we as surgeons do this particular procedure called TLIF, transforaminal lumbar interbody fusion. Once we remove the disc, guess what? We can go and insert a cage. This is an example of a cage. There are different types of cages. This particular cage is inserted from the back, hence we call it TLIF. And this particular type of cage is also an expandable cage. We go in there with a small space and then we jack it open, because what we're trying to do is we're trying to protect the curvature of the lumbar spine called lumbar lordosis. The more you protect the lumbar lordosis, the better you'll feel after surgery, the longer the surgery success rate lasts. That being said, there are other ways to fuse the lumbar spine. So there is an approach to come from the side of the spine, not from the back. This is the back, this is the side. You can come directly to the side of the spine and remove this cage, remove this disc right here. And when you remove the disc, you can then put a long cage. Remember, the more interface you have, the cage with the bone, the higher the success rate. The interface of this particular cage is narrow. So the success rate is not going to be as robust as you removing a big chunk of disc and putting a long construct, a long cage in the space with bone mixed in it. It won't take too long for this bone to fuse with this bone with the cage in the middle. Typically, when most doctors, when they do this particular approach, it's called extreme lateral interbody fusion or direct lateral interbody fusion. They usually also supplement this with screws in the back, just putting screws with small incisions and dropping a rod and stabilizing it. So that is the third type of lumbar fusion. Fourth type of lumbar fusion is you doing the lumbar fusion from the belly. You open up the belly, there are important big blood vessels called the aorta and vena cava, big arteries, big veins. You separate them and you get down to the spine. And in the spine, you get an x-ray, you get to the right level where you want to be, and you basically want to go ahead and remove the disc by cutting it with a knife and getting special instrumentation to remove the disc from this space and smoothing the surface of the bone above and bone below, preparing for a large, chunky cage to be placed from the front. Sometimes you can also put screws within the cage up top, screws within the cage in the bottom. So in this case, this entire surgery is done from the front. You have a choice of just doing a standalone surgery from the front, or you can do that front surgery and do a minimally invasive screw fixation from the back to give it support from the front, which is the front here, support from the back. The more support you have, the higher success of the surgery. Now, people ask me, why do you need a lumbar fusion? Now, there are specific indications for lumbar fusion. We'll go over them. 1, if you have a bad fracture that requires stabilization. So typically in that setting, in general, we go above the fracture, below the fracture, put screws and rods to stabilize it. Okay? There is a condition called spondylolisthesis, where one bone is slipped forward in relation to the other bone. And in that setting, lumbar fusion is indicated. What you're trying to do is trying your best to bring that bone back in position and stabilize it with screws and rods from the back. Third, a condition called lumbar instability. So some patients who suffer from conditions like Ehlers-Danlos syndrome, they're very flexible, the joints are very flexible. And in a normal person, when they bend their back forward, bend their back backwards, these bones kind of move in unison to each other, except if you suffer from lumbar instability. In lumbar instability, when you move forward or backwards, bend forward or backward, there is excessive motion of the joint, excessive motion of the bone, which then causes nerve impingement with every motion. So it's very painful. So for these patients who suffer from lumbar instability, they can benefit from lumbar fusion surgery. There is also a condition called iatrogenic instability. Iatrogenic is medically induced. So as we get older, we get arthritis that develop in our back. And that causes a lot of nerve compression, a condition called spinal stenosis, where the nerves are narrowed because a lot of arthritic changes is basically allowing no room for the nerves to breathe. So what we do is, as a surgeon, we go in there and take the pressure off. If you just take the pressure off in a small segment of the lumbar spine, and you can get away without doing a fusion. However, there are patients who have severe compression of the lumbar spine, and they have it at multiple different levels. In that setting, we do what's called a wide decompression of the lumbar spine because we want the nerves to breathe again. These are patients who, when they stand up and walk, they can only walk about a block and they feel like their legs giving out on them. And they want to be able to walk longer distance, but they can't. So they have to rest, and then they get back up and walk again, rest, get back up and walk again. So in those patients, we end up doing a wide decompression. When you do wide decompression of the lumbar spine, you are putting the patient at risk for iatrogenic instability. That means medically induced instability. The patient never had instability, but now that you've removed these structural components of the bone out, you've given the patient something he didn't have before. So to watch for that, in these cases, we end up stabilizing the lumbar spine because we know there's a high incidence of lumbar instability in these patients who just underwent lumbar decompression. These are the broader applications of lumbar fusion. There are other reasons also to have lumbar fusion, but for the most part, these are the more common ones. When you say I've had lumbar fusion, that simply means that the surgeon went in, did something to the lumbar spine, whether he put screws in the back, rods in the back, whether he put cage or he did it without a cage, or whether he put the cage coming from the side, or whether he put the cage coming from the front. Technically, that is not lumbar fusion per se. Why is that? What we are trying to do is we are trying to put the frame into the bony structures in the lumbar spine, but we're banking on the body to do the rest of the work. What is the rest of the work? The rest of the work is depositing osteocytes, which is bone cells, in where you want the fusion to occur. Because I want these two bones to be joined and become fused, I want the entire disc to be removed or to be replaced with bone. That takes time. So in a patient who is elderly, in a patient who has a lot of risk factors, in a patient who smokes, particularly smokers, that deposition of bone cells into areas where you want the fusion to occur is dropped dramatically. In these patients, you have to encourage them to completely abstain from smoking. You have to do the fusion. Sometimes you have to do fusion from the back and front. And for these patients, for sure, for vast majority of them, I also do a cage in the front. I also put a brace on them to remind them to not do anything too crazy. And I also give them something called bone stimulator. So it's a device that emits electromagnetic signal that promotes deposition of bone at the site of surgery. The best way to understand this is if you're a builder and you are building a brand new building, first step is you put the frame on, and once the frame is on, you pour the concrete. Before you go to the second floor, the concrete needs to harden. Now the hardening of the concrete is what the body does in depositing bone cells at the site of fusion. Because what we do as surgeons, we're putting the frame on, the structural support, but we're banking on the body to provide the bone deposition. For vast majority of the patients who undergo this type of surgery for the right indications, they do very well. There is an entity called adjacent segment degeneration. What does that mean? What that simply means is if you were to fuse one area of the lumbar spine, there is excessive force at the level above and the level below. So over time, that accelerates the rate of degeneration at the level above and level below. And in settings like these, you may need another surgery. So the average rate for adjacent segment degeneration is 3% per year. So if you have this surgery at a young age, there's a decent likelihood you may need another surgery in your lifetime. So we've covered different types of lumbar fusion. We've covered indications for lumbar fusion. We've explained what does lumbar fusion actually mean. And we've also covered, in general, the outcome of lumbar fusion, including discussion of adjacent segment degeneration. If you enjoyed this video, please give me a like, write a question in the comment, and follow for more.